Imagine a disease that doesn't just make you sick. It attacks your body from the inside out, melting your organs, turning your blood vessels leaky, and leaving you bleeding from your nose, mouth, and even the tiniest needle pricks. Picture a fever so intense it feels like your body's burning up, relentless vomiting and diarrhea that sap every ounce of strength, and confusion so deep you can barely remember your own name. This is Marburg virus disease, a rare but devastating illness that can kill up to 9 out of 10 people it infects. Welcome, everyone. Today we're doing a deep dive into one of the most terrifying viral illnesses out there, Marburg virus disease. It's severe, often fatal in humans, and it's actually a close relative to Ebola.
Yeah, that Ebola connection definitely gives you a sense of what we're dealing with. But Marburg, those numbers are just stark. We've seen fatality rates bounce around quite a bit, from maybe 24% in one outbreak to a really shocking 88% in another. The average sits around
50%, wow.
And it hits hard, it moves incredibly fast, and crucially, right now, here in 2025, we still don't have any licensed vaccines or specific antiviral treatments approved just for Marburg.
So if someone does get sick, it's all hands on deck with supportive care, basically.
That's exactly it. Supportive care becomes absolutely critical. It's often the deciding factor in survival.
Right, just managing everything the virus throws at the body.
Precisely. Keeping fluids balanced, trying to support failing organs. You're essentially buying the body precious time to try and mount some kind of defense.
Okay, let's dig into that. What actually makes Marburg so dangerous? How does it attack the body so viciously?
Well, the first thing is the speed. It's really abrupt. You can go from feeling fine to suddenly intensely ill. Symptoms usually pop up between, say, 5 and 9 days after you're exposed. Sometimes it's faster, like 2 days, sometimes longer, maybe up to 21 days.
21 days, that's a long incubation window.
It is, and the initial symptoms are things like high fever, bad headache, muscle aches, really nonspecific stuff at first.
Hard to pin down early on then.
Very. But from that point, the illness just accelerates rapidly.
And it's called the viral hemorrhagic fever. That sounds, well, it sounds like bleeding is a major part of it.
That's exactly right. Hemorrhagic means causing bleeding. The virus, it directly attacks the blood vessels, makes them leaky, and it messes with the body's clotting mechanisms.
Yeah.
So you get this widespread bleeding internally into organs, but also externally, nosebleeds, bleeding gums, even bleeding from needle puncture sites.
And that leads to organ failure and shock.
Yes, combined with the direct damage the virus does to the organs themselves, it's a devastating 1-2 punch.
So it's not just hitting one spot, it's going after multiple systems.
Absolutely. It's a multi-organ assault. The liver, spleen, lymph nodes, adrenal glands, kidneys, these are all major targets. The virus just replicates like crazy in these tissues, causing widespread damage and dysfunction, necrosis, essentially, tissue death.
And I heard it also messes with the immune system itself, kind of like disabling the guards.
That's a really good analogy. It's one of the most insidious parts. Marburg infects and basically neutralizes critical immune cells, cells like macrophages and dendritic cells. These are your first responders, the ones that sound the alarm. By taking them out, the virus effectively silences the body's early warning system, making a coordinated defense really difficult.
Which I imagine directly contributes to that high death rate we talked about.
It absolutely does. In the cases that turn fatal, death usually comes shockingly fast, typically within, say, 8 to 16 days after symptoms start. The direct causes are often, massive blood loss, irreversible shock because the whole system is collapsing, or just complete failure of vital organs like the liver or kidneys.
Okay, let's circle back to that phrase we used at the start, organ melting. It's incredibly graphic. What's happening biologically that gives rise to that kind of description?
Yeah, it's a powerful image. It's not literal melting, of course, like heat, but it refers to the really severe necrosis, the tissue death that the virus causes, especially in those key organs we mentioned. Think of it like a rapid, widespread decay and structural breakdown happening at the microscopic level, but the effects are obviously systemic.
Where is this necrosis most pronounced?
The liver gets hit particularly hard. You see widespread cell death, degeneration. Large areas of the liver tissue can just die off. Its structure gets disrupted. Same in the spleen and lymph nodes, extensive necrosis in the lymphoid tissues. Their normal architecture is basically destroyed, replaced by dead cells, debris, and hemorrhage.
And the adrenal glands, you mentioned them as targets too. Why is that so significant?
That's a big one. The adrenals produce critical hormones for metabolism, stress response, blood pressure regulation. all sorts of vital functions. When Marburg infects those cells, it can throw hormone production into chaos, leading to things like severe drops in blood pressure, metabolic problems, contributing significantly to shock. We see congestion, cell death there too.
And the kidneys, lungs.
Kidneys show damage too, yes. Degeneration in the tubules, protein leaking into the urine, sometimes clots forming inside, can lead to kidney failure. And the lungs aren't spared either. You can get bleeding into the air sacs, what's called alveolar hemorrhage.
So it's this combination, the widespread tissue death across multiple vital organs, plus the severe bleeding problems.
Yeah.
It just leads to this total collapse of the body's systems. That's the melting.
Exactly. It's a systemic breakdown. And you also see effects on the brain, causing confusion, sometimes aggression. And importantly for survivors, the virus can linger in the testes, causing inflammation, which has implications for later transmission.
Right. We'll definitely come back to that. Okay, so it's clearly a master of destruction once inside. But how does it get there in the first place? Where does Marburg naturally live?
Its natural home, its reservoir host, is the Egyptian fruit bat, Rosetta aegyptiacus. These bats carry the virus, often without getting sick themselves, and they can shed it in their urine, feces, saliva.
And the jump to humans, how does that typically happen?
From the bats. Yeah, that initial jump, the spillover, usually occurs when people have significant, often prolonged exposure to environments where these bats roost in large colonies. So we're talking about caves, mines.
So miners, people exploring caves, they're at higher risk for that first case.
Exactly. They're often the index cases in an outbreak because of that intense exposure.
Okay, so it jumps from a bat, but
Mm.
then how does it spread between people? Because it's not like catching a common cold, is it?
Definitely not. And this is really crucial for understanding the risk. Marburg spreads person to person through direct contact, and I mean direct physical contact, contact with the blood, vomit, saliva, urine, feces, other secretions, organs, or other bodily fluids of someone who is sick with Marburg.
Bodily fluids, got it.
And it can also spread indirectly, though this is less common, if you touch surfaces or materials like bedding, clothing, medical instruments that are contaminated with these infectious fluids, and then touch your eyes, nose, or mouth.
So during an outbreak, who's most vulnerable to catching it from another person?
Healthcare workers are at extremely high risk, especially if they aren't using meticulous infection control procedures and wearing the right personal protective equipment, or PPE. Family members caring for a sick person at home are also at very high risk. And tragically, traditional burial practices that involve direct contact with the body of someone who died from Marburg are a major way it spreads. The body remains highly infectious.
It seems really important to stress what it isn't, though. You're not going to get it from casual contact, right?
Mm-hmm.
Like sitting near someone.
Absolutely. Casual contact, like shaking hands or sharing a room with someone who isn't symptomatic or heavily shedding virus, poses a very low risk. The highest risk is that close, direct physical contact with someone who is very ill, particularly in the later stages when the amount of virus in their body fluids is extremely high, or, as I said, with the deceased.
Are any other animals involved besides the bats? Like monkeys or bushmeat?
The bat link is the most clearly established route for the initial spillover. While contact with infected non-human primates or potentially handling contaminated bushmeat could pose a theoretical risk, it's much less documented as a primary driver of outbreaks compared to that direct bat exposure or human-to-human spread.
Okay, so thinking about that, how it spreads, mainly through that direct fluid contact, starting maybe with bats or someone already sick, it makes you think. Does understanding those specific routes change how you perceive the risk? Does it feel more distant because it requires such specific contact, or maybe more immediate because you realize how it happens? What do you think? Let us know in the comments.
That's a great question. For me, actually, knowing the specifics makes it feel, well, less like some random invisible threat and more tied to very specific situations. Direct contact with the very sick, handling infectious materials without protection, bad exposures.
Yeah, I agree. It doesn't make it any less terrifying for those directly affected, obviously, but it does shift the perspective on general public risk. It's not just floating around in the air. It requires these specific, often intense exposures. All right, so we know how it attacks, how it spreads. Let's rewind a bit. When did the world first even encounter this thing? What's the origin story?
It all started back in 1967. Completely out of the blue, severe, mysterious illnesses started hitting laboratory workers. This happened simultaneously in Marburg and Frankfurt, in what was then West Germany and also in Belgrade, Yugoslavia.
Wow, multiple places at once. Did they figure out the connection quickly?
They did. They traced it back to a common source.
Yeah.
All the affected lab workers had handled tissues or cell cultures from a particular shipment of African green monkeys, monkeys imported from Uganda.
African green monkeys from Uganda. Was there anything unusual about that shipment?
There was, actually. Due to the Six-Day War happening that June, the usual flight paths were disrupted, so the monkeys got rerouted through London. And because of a transport strike there, they were actually held in London for a couple of days before finally making it to Frankfurt and then being distributed to the labs in Marburg, Frankfurt, and Belgrade.
Huh. So the thinking is they were already infected in Uganda.
That's the leading hypothesis, yes. Infected in Uganda, possibly stressed during the unusual transit, and then the lab workers got exposed while processing their kidney cells, which were intended for polio vaccine production, believe it or not.
Goodness. How many people got sick in that first cluster?
There were 30 initial cases tied to the labs, plus 2 later ones in Belgrade. Of those 30 primary cases, the ones with direct monkey or tissue contact, 25 were lab workers, and tragically 7 of them died.
7 deaths.
Yeah.
And did it spread from those initial patients to other people? Human to human?
Yes, there were 6 secondary cases, people who caught it from the primary patients. But what's really interesting, and actually a bit different from some later outbreaks, is that none of those 6 secondary cases in 1967 were fatal.
That is interesting. 0 deaths in the secondary cases. How did they get infected?
It was through close contact, again involving fluids. There were accidental needle stick injuries, someone giving an injection or drawing blood. And a pathology technician got infected when he accidentally cut himself during an autopsy on one of the deceased monkey handlers.
So reinforcing that direct contact mechanism right from the start.
Exactly. And maybe one of the most critical pieces of information that came out of that 1967 outbreak was about what didn't seem to happen.
Which was?
No evidence of airborne transmission between humans. None at all. There's a well-known example. A young man actually shared a bed with his brother right up until the brother died from Marburg. The surviving brother never got sick, tested negative later.
Wow, sharing a bed and not getting it. That really drives home the point about needing that direct fluid contact.
It really does. It was a key observation from the very beginning.
So from those first cases, what did they figure out about the incubation period? How long between exposure and getting sick?
It looked like it was somewhere between 5 and 9 days, with the average around 8 days back then.
And how long did it take the scientists to actually figure out what this new killer was?
This part is pretty remarkable, actually. The scientists, especially in Marburg, worked incredibly fast. Using collaboration and the then new technique of electron microscopy to visualize viruses, they managed to isolate, describe, and identify this completely new virus in less than 3 months after the outbreak started.
Less than 3 months. That's impressive. And that's why we call it Marburg virus.
Exactly. Named after Marburg, the city with the most cases in that first event. And it became the very first member of the filovirus family ever identified, the family that, as we said, now also includes Ebola.
That must have sent shockwaves through the scientific community.
Oh, absolutely. It revealed a whole new category of deadly pathogen. It starkly highlighted the risks of zoonotic diseases, diseases jumping from animals to humans, especially in lab settings or when handling primates, and it showed just how suddenly these things can emerge and cause chaos, even impacting vaccine production efforts.
A truly chilling discovery. Okay, so knowing all this, how dangerous it is, how it spreads, what can actually be done to prevent it, especially since there aren't specific treatments yet.
Right, prevention becomes everything. The main goal is just to break those chains of transmission we talked about, stop it moving from bats to humans, and stop it moving between humans.
So starting with the bats, how do you prevent that initial spillover?
Well, ideally, limiting human entry into known bat habitats like those mines and caves. If entry is unavoidable, say for work, then using proper protective gear, gloves, masks is essential. And during an outbreak in an area, public health advice usually includes thoroughly cooking all animal products before eating and avoiding any contact with sick or dead wild animals, which could potentially include bushmeat or monkeys, though the bat link is primary.
Okay, and then stopping it spreading person to person within the community.
The absolute key is avoiding direct, unprotected contact with anyone showing symptoms or with their bodily fluids. Suspected patients need to be isolated immediately, preferably not at home, but in a dedicated treatment facility with strict infection control. Avoiding contact with potentially contaminated items is also crucial. Bedding, clothing, needles, and safe burial practices are incredibly important. Burials need to be handled by trained teams wearing full PPE because, As I mentioned, the body remains highly infectious.
And contact tracing must be a huge part of that community response.
Absolutely vital. Finding everyone who had contact with a confirmed case, monitoring them daily for 21 days, that maximum incubation period, so if they do develop symptoms, they can be isolated and treated immediately, preventing further spread.
And you mentioned something specific for male survivors earlier.
Yes, that's critical for preventing late transmission. Because the virus can persist in semen for quite some time, male survivors need to practice safe sex use condoms for at least 12 months after recovery or until their semen tests negative for the virus twice. And just general good hygiene always helps.
Okay, let's talk healthcare settings. Obviously a huge risk area. What are the non-negotiables there?
Infection prevention and control IPC is the absolute cornerstone. It has to be rigorous. Suspected cases need immediate isolation and the use of what are called standard contact and droplet precautions even before lab confirmation comes back.
Is there a specific framework for this?
Yes, the WHO talks about an IPC ring approach. It means setting up layers of defense within the hospital, starting with screening everyone at the entrance, maybe asking symptom questions from a safe distance, taking temperatures without contact to identify potential cases early and divert them safely to isolation.
In the gear.
The PPE. Essential. Anyone entering the room or providing care needs full PPE. That means gloves, often double gloves, a fluid-resistant gown or coverall, a medical mask, and eye protection like goggles or a face shield. Maybe an N95 respirator for procedures that might create aerosols, although again, airborne spread isn't the main concern.
And hand washing, I assume?
Constantly. Meticulous hand hygiene, using alcohol-based hand rub or soap and water before putting on PPE, after taking it off, before and after any patient contact. It's fundamental.
What about contaminated equipment or waste?
Strict protocols there too. Safe handling and disposal of needles and sharps. Thorough disinfection of any reusable equipment between patients. Managing all waste bedding, dressings, etc. as highly infectious biohazardous material. Even managing visitors needs to be carefully controlled. And it's worth remembering, PPE is really the last line of defense. The hierarchy of control starts with things like having proper isolation rooms, good ventilation, clear protocols, training, trying to minimize the exposure risk before you even need the gear.
Beyond the hospital walls, what about the broader public health response?
Community engagement is key. Getting clear, accurate information out to people in affected areas about the risks, the symptoms, how to protect themselves, where to seek help building trust is vital. Plus, you need strong surveillance to spot cases early, good lab capacity for quick diagnosis, and encouraging people who might have been exposed to report symptoms immediately. It all works together.
Okay, let's shift to diagnosis and treatment. If someone gets sick, you said early symptoms are vague. How do doctors figure out it's Marburg?
Yeah, that's a major challenge. Fever, headache, muscle aches. It looks like malaria, typhoid fever, lots of other things common in the regions where Marburg occurs. Suspicion really ramps up when you have those symptoms. Plus, a relevant exposure history traveled to an outbreak area within the last 21 days, contact with bats or caves, lab exposure, or contact with a known case.
And if Marburg is suspected, how is it confirmed? What are the tests?
The main diagnostic test, especially early on, is RT-PCR. It detects the virus's genetic material in a blood sample or other fluid, but sometimes, very early in the illness, the viral load might be too low for PCR to pick it up. So if suspicion is high, a negative test might need repeating a few days later.
Are there other tests?
Yes, labs can also use tests that detect viral proteins. Those are called antigen capture ELISA tests. And later in the illness, they can test for antibodies, the body's immune response, using IgM and Ig ELISA tests. IgM appears earlier than IgG. Virus isolation, actually growing the virus in a lab, can be done, but that requires very high biosecurity labs, level 4, so it's not routine diagnostics. And of course, ruling out those other diseases like malaria is crucial. And handling these samples is incredibly dangerous, requires specialized procedures.
Okay, so diagnosis confirmed. But as we established, no specific cure exists yet in 2025. It's all about that supportive care.
Exactly. Intensive supportive care is the treatment. It's about managing the complications and keeping the patient alive long enough for their own immune system to hopefully, potentially, clear the virus. A huge part of that is managing fluids and electrolytes. With severe vomiting and diarrhea, patients dehydrate incredibly quickly, which can lead to shock and kidney failure. So giving intravenous or IV fluids is often life-saving. Sometimes oral rehydration solutions or feeding tubes are used if possible.
What else is involved in that care?
Maintaining oxygen levels, supporting blood pressure if it drops, which it often does, giving blood transfusions if there's severe bleeding to replace lost blood and clotting factors, And managing symptoms, pain relief, fever reduction, anti-nausea medications, trying to provide nutritional support, it's really intensive, round-the-clock care.
And you mentioned secondary infections earlier.
Right. Because the immune system is compromised, bacterial infections can easily take hold. So patients are often given broad-spectrum antibiotics to prevent or treat those secondary bacterial infections.
Is there any research into specific drugs or vaccines? Anything looking promising?
Oh, yes, definitely. Research is ongoing and quite active. Several experimental antiviral drugs are being looked at. Remdesivir, which people might know from COVID-19, has shown some activity against filoviruses in lab settings and some limited clinical data. It's sometimes studied alongside experimental antibody therapies. Monoclonal antibodies, specifically targeted against Marburg, are also in development.
What about vaccines? That seems like the ultimate goal.
It is. And there's progress there, too. Several vaccine candidates are in different stages of clinical trials. One prominent example is a vaccine using a chimpanzee adenovirus vector, CAD3, developed by Sabin. That one's actually in phase 2 trials right now in 2025 in places like the US, Kenya, and Uganda. There are other approaches too, like DNA vaccines and vaccines using the RVSV platform, similar to the successful Ebola vaccine. So while none are licensed yet, the fact that candidates are progressing through human trials is definitely a hopeful sign compared to a decade ago.
And treatment requires those specialized isolation centers, right? You can't just manage this in a regular hospital ward.
Absolutely not. Marburg requires care in dedicated Ebola treatment units or similar high-level isolation facilities. They have the infrastructure and trained staff to provide that intensive care safely, minimizing risk to healthcare workers and others.
And for the survivors, what happens after they beat the virus?
Surviving Marburg is a monumental feat, but it doesn't always mean a return to perfect health immediately. We know the virus can persist for months in certain immune-privileged sites like the eyes, the central nervous system, and, as we discussed, the testes in men. This persistence is why those safe sex recommendations for male survivors are so important. And survivors might face long-term issues like joint pain, fatigue, eye problems, and psychological trauma. Survivor support programs are really needed.
So bringing it to today, 2025, is Marburg still considered an active threat?
Yes, unfortunately it is. While it doesn't cause constant large-scale epidemics, it remains a very real and serious risk, especially in certain parts of Africa where the Egyptian fruit bat reservoir exists.
Have there been recent outbreaks or cases?
There have. Fairly recently, Tanzania experienced an outbreak declared over in March 2025. It was small, 10 cases in total, 2 confirmed, 8 probable, but tragically, the case fatality rate in that specific cluster was 100%.
100%.
Devastating. Absolutely. And even though that outbreak is over, the virus is still present in the bat population there, so the potential for reemergence remains.
And it's not just Tanzania, right? Other countries too.
Correct. In recent years, we've seen cases or outbreaks reported in places like Rwanda, Ghana, Equatorial Guinea, and Uganda as well. It confirms that the virus is still circulating in these endemic regions, periodically spilling over.
So how are global health organizations like the WHO monitoring this?
They maintain constant surveillance, work closely with countries in affected regions, provide technical support, help strengthen lab capacity, and assist with outbreak response when cases occur. The focus is always on early detection, rapid containment, and engaging communities.
Is there specific travel advice related to Marburg?
Generally, travelers to areas where Marburg might occur are advised to take standard precautions, avoid caves and mines where bats roost, avoid contact with sick people or dead bodies. But based on the current situation, with outbreaks being localized, the WHO isn't recommending broad travel or trade restrictions. It's more about awareness and specific precautions if you're in an affected zone. So the status now is ongoing vigilance. Marburg remains a high-consequence threat in certain African regions, even if outbreaks are sporadic. Preparedness and rapid response are key.
It really is a sobering thought, isn't it? That despite everything we've learned since 1967, all the science, the global health efforts, outbreaks like the recent one in Tanzania can still happen and still be incredibly lethal. It makes you wonder, will we ever be truly safe from diseases like Marburg as long as they exist out there in nature, circulating in wildlife?
That is the fundamental question with zoonotic diseases, isn't it? The interface between humans, animals, and the environment is where these risks emerge. Constant monitoring and preparedness seem to be our best strategy right now.
What do you listening think? Does understanding Marburg's story, its origins in bats, its transmission routes, make you feel more or less secure about our ability to handle these kinds of natural threats? We'd love to hear your perspective in the comments. Thank you so much for listening. Please subscribe. And as always, have a nice day or good night and stay safe. See you on the next one.